Welcome everyone to our orthopedics webinar series. My name is Sarah Hibner, and on behalf of Premier Health and Premier Health's orthopedic specialists, I'd like to thank each of you for attending this evening. We are so glad to have you with us. Tonight, we are here to discuss joint pain. As you may know, joint pain is a common issue for many. You are not alone. The good news is there are options available to help reduce your pain, increase mobility, and get you back to the activities you love. Our physician expert, Dr. Davis, will give a brief presentation this evening on common causes of joint pain and practical tips for managing it. He will also answer some of your questions following his presentation. So let's start off the evening by introducing our speaker. Dr. Davis earned his Doctor of Medicine degree from the University of Cincinnati College of Medicine and completed an orthopedic surgery residency at Mount Carmel Health System in Columbus, along with an adult reconstruction fellowship at the Southern Joint Replacement Institute in Nashville. Dr. Davis specializes in orthopedic surgery, and he is a member of the American Academy of Orthopedic Surgeons and the American Association of Hip and Knee Surgeons. Additionally, he has participated in medical mission trips to Africa and Mexico. Dr. Davis sees patients at his Middletown and Monroe offices. He also practices at Premier Orthopedics, one of the largest and highly trained orthopedic and sports medicine practices in Southwest Ohio. The practice offers the full range of treatment options from exercise and physical therapy to injections, pain management, and surgery where needed, including minimally invasive, arthroscopic, and robotic arm knee procedures. With nearly 30 doctors and more than 12 locations, Premier Orthopedics is ready where and when you need help. Thank you, Dr. Davis, for being with us this evening, and I will turn the presentation over to you.
All right, thanks, Sarah. So welcome everybody who has come. Hopefully tonight will be informational for you. As Sarah said, my name is Rick Davis. I've been with Premier Health now for about 5 years. I do mainly hip and knee replacement, as well as the revision or kind of second or third time surgeries with that, probably about 70% of my practice. And I also take care of fracture care. That means coming to the ER, a patient may fall and break something. I also take care of that as well. So let's jump right in and get started here. So topics for discussion today, we're looking at common causes of joint pain, getting the proper diagnosis, and then different treatment options that you have, both from non-surgical treatment options, and then talking about surgical treatment options and when this is appropriate as well. And then like Sarah mentioned as well, we'd love to have some questions at the end. I'd be happy to answer those too. So it's always good to start looking at what a normal knee looks like or a normal hip looks like prior to discussing what an arthritic hip or knee looks like. So I will be focusing on hip and knees today, as this is most of my practice. So if you look on the left side of the screen here, this is just a cartoon view of what a normal knee would look like. This is your thigh bone here. The end of that is a smooth cartilage. This is your leg bone or your tibia, and the diagram here is showing the meniscus as well, which is a C-shaped kind of cartilage cushion that sits between the bones. So if we look on the X-ray over here on the right, once again, this is your thigh bone, this is your leg bone, and this is your knee joint, kind of the space in between. A normal knee does have a space. That's where your cartilage sits. So when I look at an X-ray and I see a space in between the bones, I know that's a fairly normal knee and that knee that does not have a lot of arthritis. So common causes of acute joint pain, meaning less than 3 months, or a ligament sprain or a muscle tear. Say you're walking down a flight of stairs or running, you kind of tweaked your knee. That can be one of the causes of that. You can get fractures or breaks in the bone, as well as meniscal or cartilage tears that can cause pain as well. Many of us have had a tendonitis at some point where a tendon gets inflamed and causes pain. There's also gout and other autoimmune diseases too. Common cause of chronic joint pain, chronic meaning greater than 3 months typically. The most common by far is arthritis, and within that is osteoarthritis, which is kind of the normal arthritis that you hear about. Rheumatoid arthritis is more of an inflammatory arthritis that can occur, and that's more of throughout your entire body. And then post-traumatic just means you've had a previous injury, such as a sporting injury when you were younger, or even a car accident or things like that that caused a break or ligament damage and then developed into arthritis down the road. You can get meniscus tears that are called degenerative, meaning as the cartilage wears out, it can start to tear. And then also different instability, meaning the ligaments itself in the knee don't provide the same stability. and that can cause arthritis to progress as well. So osteoarthritis is by far the most common type of arthritis that we see. It affects roughly 27 to 30 million Americans. It's a frequent cause of chronic joint pain. It affects the knees, hips, hands, spine, pretty much any joint within the body. And we know that if you have arthritis in one area of your body, you're more likely to have it in another area as well. This represents a loss of normal cartilage, meaning cartilage on the end of your bone. So any arthritis throughout your body, it's simply when the cartilage itself starts to wear down, and instead of nice smooth surfaces that kind of glide and move easily, they become roughened surfaces that can cause pain and swelling and even some motion restriction. And this is something that develops over time. We're talking about at least months and months, usually over a year's time. Currently, there is no cure to this. There are a lot of treatments focused on relieving your symptoms and improving function, and there's quite a bit of research going on now to try to find a cure for that. Many of you have probably heard of stem cell research and things of that sort. So this is a picture of what an abnormal knee looks like, or an arthritic knee. We see on the left here, it keeps going back to me, okay. There we go, I'll just stop using the cursor for now. As you can see on the left side there, so the cartilage that used to be kind of smooth now has those areas that's kind of broken up, and that's as the cartilage is wearing down. So as we look on the x-ray on the right side of that x-ray, there's no space in between the bones. And instead, the bone is just rubbing the bone, and that's just end-stage arthritis when you've worn out all that cartilage, okay? And that can be on the outside or lateral aspect, or on the inside or medial aspect of the knee. Either way, it causes pain, and that is what arthritis is. Now, if we look at the hip joint, so the hip joint on the left here is a normal-looking hip joint. Once again, smooth cartilage on the end of the bone. A hip joint is a ball and socket joint. So when you have a normal hip, you have nice, smooth cartilage. As we look over here on the right side, you see that cartilage is worn out, and instead of nice, smooth cartilage, you instead have basically no cartilage, and you have little bone spurs here that they're showing. Once again, this causes pain and swelling in the hip joint itself. So the treatment of arthritis in general is what we call a multidisciplinary care approach, meaning multiple physicians and therapists or even nutritionists that kind of help the patient in different ways. So this typically will start with your primary care physician. They can start with medications and so forth, even get a prescription for a physical therapist to work with you. Sometimes there are sports medicine trained physicians that are not surgeons, but they take care of sports medicine related injuries. There are dietitians and nutritionists that can help with weight loss. Rheumatologists can help with the inflammatory type arthritis. And then once again, physical and occupational therapists help in a significant way from a muscle strengthening and also joint mobility or movement standpoint to try to help delay any surgical intervention. And then the orthopedic surgeon is also part of that care team as well. So the question always arises, when do I need to see a doctor? I generally tell people, if you have an injury and it tends to get better within 2 to 3 weeks, you can probably just ride that out and it'll get better on its own. When you have persistent pain or swelling, locking sensations, or clicking in a joint, that's a good indication that you want to see your doctor. You can start with your primary care doctor, or you can even come to the orthopedic surgeon as well. Pain that is not relieved by rest, activity modifications, and over-the-counter medications like Tylenol and Advil. And then once again, pain that persists and prevents you from doing your normal daily activity. If it persists for more than a few weeks, or definitely even a few months, definitely someone, that is the time to go see someone for that. So non-operative treatment, meaning non-surgical treatment, is always the first line, and the goal is to delay a major surgery. This is definitely for younger patients and also patients with multiple medical problems. But in general, when I see a patient, the goal is to not do surgery unless that's kind of the last resort, or if they've tried many other things. The goal, once again, is to decrease your pain and improve your function. And this can be done in multiple different ways. The first thing we talk about is kind of briefly here is this lifestyle modification. So diet and nutrition is very important. Well-balanced diet, low fat, low cholesterol. There are certain natural anti-inflammatory foods you can eat, which are listed here. And then fruits, vegetables, and once again, alcohol in moderation. Weight loss is very important. I would say maintaining a healthy weight should be the goal. As you see kind of down in the middle of this slide, BMI, which is body mass index, is a measure we use pretty universally to gauge this. It's your weight over your height. In general, a goal BMI is 20 to 30. The benefits of this extend beyond just the arthritis pain, just for your general health, from a decrease in your chance of diabetes, heart disease, things like that. So one interesting fact that I always like to tell people is, your knee actually feels 7 times your body weight when you're going down a flight of stairs. When you're going up a flight of stairs, it's 4 times your body weight. So even losing 10, 20 pounds makes a significant difference in the weight that your knees feel when you're doing that activity. Most surgeons nowadays do have a BMI cutoff. That means that over a certain BMI, we don't recommend surgery. My BMI cutoff is generally 40 for knees and 35 for hips. That's different on individual surgeons, but that 40 number, 35 to 40, is a pretty common number. And that's not just an arbitrary number. There's been a lot of studies looking at your risk of complications after a surgery. And once you get over that number, your risks go up, and we never want to see that as a surgeon. We never want to see a complication with our patients. Exercise and activity is very important. In general, staying active, using your muscles helps to reduce pain and improve function. As your arthritis progresses, this becomes more difficult. So a lot of times this will be an activity modification. Maybe instead of walking, you do a stationary bike or a recumbent bike, things like that. I'd be happy to talk about that later if anybody would like more information on that. But in general, strengthening your muscles takes pressure off the joints and helps you to get back to doing things with less pain. We are talking about smoking cessation as well. So once again, for my patients, I strongly encourage all my patients to quit smoking prior to surgery. It definitely helps with your overall lungs while undergoing a surgery and just with your general health. And I'd say in my experience, people have been looking for a reason to quit smoking, and patients are just as happy that they quit smoking as they are with their joint replacement outcome, because they know that long-term, this will benefit them in many ways. Different thermotherapy can be used. Cold, heat, and general cold reduces swelling and inflammation. It can block some of the skin nerves and impulses to the joint. Heat as well. Some patients say they know alternating cold and heat can help if you have a swollen joint and so forth. In general, there's a couple of classes of medications that we try that are over-the-counter medications. Acetaminophen or Tylenol is the most common. In general, you want to take less than 3 to 4 grams per day. So most Tylenol arthritis pills are anywhere from 500 to 650 milligrams. So you can take that multiple times a day and still get some relief from that. Anti-inflammatories is also a common medication that we prescribe. There's many different names of these. You'll see kind of in the pictures there on the right. Whatever one typically works best for your body is what we recommend. There are some prescription ones that sometimes work better, but oftentimes just taking over-the-counter Advil or Aleve will work well. There is an increased risk of gastrointestinal or kidney complications for long-term use of these. That's just something we counsel our patients on as well. And the primary care physicians are very good about watching that too. There are different nutritional or natural supplements that can help. Many of you have probably heard of glucosamine and chondroitin sulfate. The studies on this have shown some potential benefits. So what I typically tell patients are, if you try it and it works, it's fine to take. If you try it and it doesn't seem to make any difference, you can stop that. They can be kind of expensive. The other one are natural anti-inflammatories. So I have a lot of patients who take turmeric. It actually works very well. It's essentially equivalent in my mind to ibuprofen or Aleve. Physical and occupational therapy. The goal is to reduce pain, to improve your motion and build strength. It's called prehab, even prior to a joint replacement. Exercises that can really help build your strength, build your balance, and your mobility. And physical and occupational therapy can only help you with your general strength and just daily living in preparation for a joint replacement at some point down the road. So it's a very vital part of your post-surgery recovery, but it can also be very vital prior to surgery too. So there's different exercises. We won't go through all these now, but exercises that we can give you as a handout in the office that our Orthopedic Academy has done a great job of putting together, and also some that your physical therapists will give you too. They can help to strengthen your glutes and your quad and hamstring muscles is kind of what we focus on. Next, kind of after the medications and therapy come the injections. So there are cortisone injections, and there are gel injections and other things like that. So we'll go through these real quick. Cortisone injections are a strong anti-inflammatory that's natural that goes into your knee joint. It treats your symptoms. It does not regrow the cartilage, but typically first-time cortisone injections could last you 3-4 months at least. As long as they're working, we can continue those. The next option are gel shots or viscose supplementation. There have been some studies that show they do help, some that show they don't. In general, I use gel injections for patients who have tried cortisone injections. They no longer work, and they're really just not ready for a knee or hip replacement yet. And that's when we can try a gel injection. I kind of think about it like motor oil. It's clear and nice. It basically lubricates the joint and also has some anti-inflammatory effect as well. So what's next? So you've tried medications, you tried activity modifications, you may have tried some physical therapy, you've tried injections, and your knee or hip still hurts. So we'll kind of go through this, what are my options now? And when will I know it's time to have surgery? So in general, I tell people the decision on when to have surgery is a quality of life decision. So when you've tried other options, they're no longer working, and it's affecting your daily life and your daily quality of life. And that's the time to have a discussion with your orthopedic surgeon about what are my surgical options to get me feeling better. So in general, there's arthroscopy and there's joint replacement. So we'll start with arthroscopy here first. Different terms you may have heard, people have had their joints cleaned up, they had a meniscus tear trimmed out or repaired. Sometimes people will say, the doctor scraped out my arthritis. So arthroscopy is when you make basically two kind of poke hole incisions on the front and side of your knee, and you use kind of pencil-sized instruments to go in there. There's a camera, and then instruments basically trim out a meniscus tear or clean up some of the lost cartilage on the end of the bone. This does allow for a good visualization or view of the entire joint, kind of all the compartments around the joint as well. The good things about arthroscopy, it's very minimally invasive. Typically, the recovery is very quick, 2 to 6 weeks. It's outpatient and a very low risk of complications. It's best done when you fall, you twisted your knee, and you have a meniscus tear, and you don't have a lot of underlying arthritis. So what I tell patients, if I get an x-ray and I see bone-to-bone arthritis, I don't typically recommend a knee arthroscopy, because while I can go in there and take out some of the torn cartilage, they still have the bone-to-bone rubbing. And that in general will continue to cause pain. You may get a few months of relief or a year of relief, but ultimately you're going to come back to the same point and needing a knee replacement. So in general, like I said, it's better for pain less than a year, mechanical complaints, meaning like a new onset of locking or catching with a maintained joint space on x-ray, meaning you have not lost a lot of the cartilage. So when should I consider a joint replacement is the question I get a lot. So kind of like I just said, pain is affecting your quality of life. Conservative treatment, meaning the medications and injections and so forth, are no longer working, and the expected results and your improvement in quality of life are worth the risks of undergoing a surgery. So let's start here by talking about knee replacement. So knee replacement is a very common procedure done in the US, about 800,000 per year is the most recent number I could get when I was reviewing this. And there are total knee replacements versus partial knee replacements. So you can see on the picture on the bottom left, those are two examples of total knee replacements, and we'll show you some more better images going forward here. So here is a candidate for a partial knee replacement. So if we look at the x-rays here on the left, here's your femur, your thigh bone, your tibia, and your leg bone. The joint space on the outside of your knee is maintained, so you still have a good space between the bones. As we come to the inside of the knee, that joint space goes away and your bone touches the bone, okay? On the side view, this is your kneecap or your patella, and there's still a space between the bones there. So we know that all the arthritis in this patient is focused on this area here, okay? So this patient is a candidate for a partial knee replacement, where we simply kind of replace the end of the bone and this area here. So these are some views of the partial knee replacement that I use. So this is, you can see it's kind of a metal cap on the end of the bone. So this picture here equates to this x-ray here, okay? And this kind of side view of that equates to this picture here as well. And there's a plastic liner that sits in between those. So this is kind of the side view of your knee. And this view in the middle here is basically straight on x-ray from after the partial knee replacement. So metal cap on the end of the bone here, metal cap on the end of the bone there, and then a plastic liner in between, okay? And this is just another graphic of that. So one of the advantages of a partial knee replacement is that if you see on the bottom left picture, the two kind of crossing green structures, those are your ACL and your PCL. So you actually keep the main ligaments in your knee on the inside, and then your MCL and also on the outside. So in general, patients feel that it just feels more natural to them because you have your normal ligament stability. And in general, the recovery is about 2 weeks quicker than a total knee replacement. So if you look at this picture here, so this is a total knee replacement candidate. This is before surgery. So the x-ray on the far left, once again, bone touching bone is never a good thing. That's end-stage arthritis. And if we look at the side view here of the knee, you have a bone spur on top of the patella, and then the joint space between here really narrows down as you come here, showing that there's arthritis between the kneecap and the femur bone or your thigh bone as well. So multiple areas of arthritis in the knee. A total knee replacement is the best option for that patient. So this is the total knee replacement that I use commonly by a company called Microport. And this is an x-ray of what a knee replacement looks like after the surgery. So it's simply a metal cap on the end of the entire bone and a metal cap on the entire top of the tibia bone here. And the space there is actually filled with this plastic liner you see on the left. It does not show up on the x-ray. Okay, so you can see the difference between a knee replacement side and a normal knee here. So the question is always, what can I expect with knee replacement recovery? So in general, like we said, a partial knee replacement gets about 2 week quicker recovery. It's just typically less surgery on the knee, so you're not quite as sore. I call the first 2 weeks after a knee replacement the "what did I get myself into" phase. It's just kind of a sore period from the surgery and so forth. You're sent home with an ice pack machine, anti-inflammatories if you're able to take those, and then pain medicine is needed as well. You're working with a physical therapist 2 to 3 times a week for the first 6 weeks to get your knee motion, okay? In surgery, I make sure you actually get full motion of that knee. Your body likes to make scar tissue after any surgery, and your job is to kind of train that scar tissue to be mobile and to move. And that's the job of the physical therapist and specifically the patient undergoing the surgery to put that work in as well, okay? Partial or total knee replacement is outpatient surgery nowadays. So you will come in, you'll have the surgery. Once you wake up and all the anesthesia wears off, you'll work with a physical therapist and you'll get up and actually walk with a physical therapist. If you have stairs at home, you'll walk a flight of stairs with them to show that it's safe to do that. And then we're getting you home the same day. So I'll see you at 2 weeks in the office and then at 6 weeks in the office. And by 6 weeks, you're off your cane and your walker, and you're really ready to start getting back to activity, okay? Before you're ready to go on long hikes or longer distance walks, it takes about 3 months. So total recovery is about 3 months, and you can make small improvements over the first year after a knee replacement. But the kind of key time periods are the 2 week, the 6 week, and then the 3 month time period, okay? I've had people go back to work as early as a few weeks, even a few days. In general, if you're going back to a desk job, it's anywhere from 4 to 6 weeks. If you're going back to a manual labor job or a job that you're up and walking a lot, it's typically about that 3 month time period. So some exciting kind of things with new and upcoming technology within knee replacement that we're currently using, and some things that will be coming up very soon. So right now at the Atrium and at some other locations within Premier as well, it's robotic assisted knee replacement. So this is the Zimmer Biomet Rosa system. So there's different manufacturers to do this. So this is what I've been using for the past few years. So I love to have the picture here so people don't think it's like the Jetsons and like a robot in the surgery room doing the surgery. So the surgeon is still making the bone cuts. It's still making the decisions. The robotic arm is kind of helps to align the cutting blocks that we do to make the bone cuts. And it can add some precision to the surgery itself. And there's some double checks with the computer system to look at your balancing and your cuts. And it's very helpful. So I've enjoyed using this, and I think it does have some benefit for the patients, just from a recovery standpoint and so forth. On this technology standpoint, from your phone or your iPhone, if you have that, there's an app that we've been using called My Mobility. It's something that I've worked with the My Mobility group and kind of personalized the exercises and so forth and the routines we have before and after surgery. And the app is really great. It actually reminds you to do your exercises. It kind of follows you along. And there's also interfaces with an online portal that the surgeon can look at as well. Okay. So there's options for this. There's options to get a free iWatch. I'm using that term right. And then even to purchase that down the road if you would like. It's basically free for 3 months, I believe, and you can purchase it down the road if you'd like as well. So, or just return it. So it's cool technology, kind of the next step for us as well. And then something that is very new and upcoming that we hope to get here within the next few months. This is also through Zimmer and Biomed. It's called Persona IQ. So this is, I just learned about this recently and it's coming out. So as you can see in the bottom left, so this is a knee replacement, normal parts here, and this little stem that you attach to this, it's actually called a smart stem extension. And this actually calculates data and sends it to the surgeon so they can see it for your knee motion, how many steps you're taking, how much progress you're making. And it's really cool. So, there's no tracker on it or anything like that. You can turn it off at any time, but it can really help the patient be very much involved in their own care to know, hey, I made this progress for the past week. I'm walking more today. And it's a great way to just help collect data in a way that we can look at for patients as a whole to help improve their overall outcomes and kind of quicken that outcome as well. So very cool technology coming up that we hope to be implementing here very, very soon. So let's switch gears here. We'll finish up with hip replacement and total hip replacement. So hip replacement's done about 450,000 a year was the most recent number I could find here in the US. So if we look at the x-ray here, this is actually the right hip of my cursor. This is the left hip. So a hip is once again a ball and socket joint. There's no space between this ball and socket. If we look at the contralateral left side, you see the space between the bones there. That's a more normal hip. There's still some arthritis in that hip. But if you look at the right side, that's bone to bone, and the actual head is kind of flattened, all right? So this is a patient who's a good candidate for a total hip replacement. So total hip replacement, there's many, many different manufacturers. They all work essentially the same. There's different shapes of the implants and so forth. Hip replacement parts are made of titanium for the stem that goes in the femur bone, and then the cut part. The head is typically ceramic or metal. And the liner is typically a polyethylene, so the high cross-link polyethylene. So if you look at kind of the model here, this is the new ball, the socket's kind of in the bone here, and that stem sits down the center of the femur bone. Think of the femur bone, your thigh bone like a tube, and that implant kind of sits down inside the tube. So here's an x-ray of different types of hip replacements, okay? Different manufacturers, different types of hip replacements can be used for certain anatomical abnormalities, or how people are made can differ. So I will use different implants based on patient's anatomy just to get them the best outcome. So when you have a hip replacement, you walk on it, that's actually what you walk on. The new ball here and then the socket. So what can you expect with hip replacement recovery? Okay, so different things that are currently being done with hip replacement. So there's different approaches to a hip replacement. You may have heard these terms of an anterior approach or a lateral or a posterior approach. It's basically the surgeon's preference on how they go into the hip joint. There has been some data to suggest that the anterior approach or to the front, your recovery is about 2 weeks quicker. It's just less trauma to the muscle tissue. You don't have to go through your gluteus maximus, your big kind of bottom muscle. But by 6 weeks, the results are the same. So I see very similar results in patients I do a anterior or front approach on, and those that I do a posterior or a side approach on, okay? The end result is much the same. In general, hip replacement recovery is quicker than a knee replacement, mainly because you don't have all the intense therapy. Hip joints tend to bounce back a little quicker. And patients for sure, the first time they get up and stand on this, the arthritis pain that they had is gone. So even the first day you get up and stand with your therapist, that hip pain is gone. You have the muscle soreness and the soreness from the surgery, but it's just different. And patients reproducibly tell me that same thing. Okay. So once again, hip replacement is an outpatient procedure. You come in, you have your surgery. Once all the anesthesia meds wear off, you get up once again with a physical therapist and you walk. You can walk a flight of stairs. You can walk around distances that you need to at home, and then we get you home the same day. Typically, you're working with a physical therapist 1 to 2 times a week for the first 4 to 6 weeks. Some people bounce back quick and they don't need as much therapy. Others need a little bit more just to kind of get their muscle soreness down and so forth and get back to life and activity. So in general, the more fit you are going into the surgery, the easier your recovery will be and you're getting back to life. So from a getting back to work standpoint, usually by 6 weeks, I'm letting people get back to anything they want to do. Sometimes you can even go back to that manual labor job at 6 weeks. I'm giving people up to 3 months if they need that. But especially the younger patient population and those who are more fit going into it can typically bounce back much quicker. Either way, small improvements over that first year. But in general, the recovery is a good 4 to 6 weeks quicker typically than a knee replacement. From an anterior or front incision versus a posterior or side incision approach, there are some different hip precautions that your physical therapist will go through to make sure that ball stays in the socket. I'd be happy to answer any of those questions you may have going forward here as well. So just to kind of review here for both hip and knee replacement, joints give us freedom to move and perform our daily tasks. When joint pain and arthritis affects our activity and quality of life, it's really time to seek help. So one of the things I hear very, very commonly is patients who have a joint replacement and have made that decision to go forward with it. Once they have it, they often will say, I wish I would have done this 3 years earlier or 5 years earlier, just because they realize that the pain relief they can get from that and the quality of life they can get improvement in that is tremendous. So from a surgeon standpoint, it's great to see patients recover quickly, get back to life and activity. And I love people coming back into the office and showing me videos of what they've done, pictures of what they've done, mountains that they've climbed. It's awesome to see. So, there are many options, both non-surgical and surgical, to help with pain relief and to get you back to an active lifestyle. So thank you very much for attending. The Premier Health website is at the bottom right there. This is our office number there from Middletown and Monroe. If you all have any questions, would like to continue this conversation outside of this, we would love to see you. Okay. So now is the time for questions. So I'm going to hand it back over to Sarah and see if we have any questions that I can answer.
Okay, great. Thanks, Dr. Davis. As a reminder, if you'd like to ask a question, please type it into the Q&A. You can find the Q&A by hovering your cursor over the bottom of your Zoom window. So we'll go ahead and start with a question. Should I have both knees replaced at the same time? Good question. I hear that a lot. So there are indications to do that, and there are kind of from a medical standpoint. So people who have really any type of heart issues, the recommendation is not to do both at the same time because your risk to your heart is slightly higher with having both done. In general, I try to kind of talk people out of getting both done at the same time because it's a lot of stress on your body and it's a lot of physical therapy. And you kind of have to have the right mindset going into it. But I'm open to have that conversation with specific individuals. Typically, it's someone who is younger, does not have really any medical problems. People who are in their 50s or early 60s and are very active and really just want to get back to things. So the only real contraindication or reason to not have it is significant heart issues. But I'm happy to have that conversation with people when they come in. Okay, next question is, how long will a knee replacement last? Great question. So what I tell patients in the office is nowadays knee replacement should last you 20 to 30 years. Okay. I actually just saw a patient recently that a knee replacement had lasted 30 years from 30 years ago. The way they used to process the plastic pieces that sit between the metal parts, some would last for 5 years, some would last for 25 years. So nowadays it's much more reproducible.
So we should be seeing a good 20 to 30 years out of most of these knee or hip replacements.
Someone along that line, how long should I wait between having my knees replaced?
So I'm typically telling people to wait about 6 weeks at the earliest time. I push it to kind of 4 weeks before. I've had some, teachers who come in over the summertime want to get both knees replaced in a short period of time before school starts again. So you can do kind of that, but that 4 to 6 week mark is usually what I recommend. It allows that first knee to get through your therapy, starts to feel better, your swelling goes down, because that'll kind of become your good knee once you go into the next surgery.
Okay, next question. I have bone-on-bone knee with gel injection. Is riding a bicycle good or bad for my knee?
Sure. So riding a bicycle is very good for your knee. So I love to see patients doing exercises that don't cause the constant pounding. So I try to steer people away from trying to walk longer distances or use a treadmill or things like that. I would rather you do things like a recumbent bike, a stationary bike, even a road bike if you feel safe doing that, or an elliptical, things that don't cause kind of the joint pressure. So all those activities we've stated, they really help to build the muscle up and they don't irritate the joints nearly as much.
Okay, another exercise question. When can I play golf and pickleball after my knee replacement?
Yeah, so I'm a big golfer, so that would be an important question for me as well. So, so from a golf standpoint, at the 6 week mark, really after hip or knee replacement, I tell people they can start getting back to it. So I kind of use the every week or so, add some new ins. You kind of start putting and chipping. Then you kind of go half swing with your wedges. You can kind of go to your irons, kind of half swing, and then kind of progress back to full swing. So you're not going to do any damage to the joint, but the twisting motion that you have when you swing back and through can just cause different forces along the joint. They can kind of tweak some of the scar tissue. So you may feel some twinges here and there. So it's kind of a slow progression back. But doing those activities is not going to hurt that. From a pickleball standpoint, it's a lot more pivoting, jumping, moving. I had a guy who did partial knee replacement on. He went back to pickleball like 4 weeks. I really wouldn't recommend that. That seems kind of soon, but he did well. So typically I'm saying at that 6 week mark again, you can kind of start getting back to those, but you'll notice that the pivoting, planting activities where you're kind of really twisting on that joint, you kind of feel some tweaks in that scar tissue early on. Once again, not doing any damage, but it's something you have to kind of slowly progress back into.
At what age do you recommend getting a joint replacement?
So good question. I mean, it's really dependent on the individual person. So, I've done hip replacements with people who are in their 20s who have had injuries like when they were in their teens. Okay. So age is not necessarily a determining factor. It all depends on your level of arthritis and what you've tried, meaning non-surgical things that you've tried. And if you've tried a lot of things and they're not working, and it's really limiting your quality of life, then we have that conversation. So part of that is just explaining to patients that, if you have a joint replacement earlier on in your 40s or 50s, the likelihood of you having some revision or second time surgery in your 70s is fairly high. So just a conversation that we have, but I don't really have an age limit on lower or older. It's all depend on the individual patient.
Okay. Someone is asking that they say they're not ready for surgery. So what is the best route for their knee issues?
Sure. So the best route is kind of figure out exactly what's going on first. So whether that's an x-ray is always the easiest place to start. And then from a treatment standpoint, it's kind of the treatment rung of medications, Tylenol, anti-inflammatories, and then starting with injections if those aren't working. Cortisone gel injections, one thing we didn't talk about a little bit is more of the kind of PRP, platelet-rich plasma injections that are becoming more popular. So there's other out-of-pocket injections you can try as well for patients who really just don't want a surgery. So there's plenty of options to do, but that's kind of the typical stepwise approach.
Okay, there's a question on injections. How many times can you receive cortisone shots before you decide to have a knee replacement?
So in general, as long as the cortisone shots are working, I don't see there's really a limit to them. Most surgeons will say, no more than every 3 months or so can you get an injection. But as long as they're working, I guess a successful injection, is my mind, is working at least for 3 to 4 months. If it's working that long, you continue those. If you have an injection that only lasts you for a week or two, then you say, let's try something different. So there's really no limit to how long that you can get them for, as long as they're working.
Is arthritis hereditary or is it from age?
So both. So there are, if I see people routinely who say, well, my parents had their knees replaced, and their parents, I guess not their parents, but their, other family members, aunts, uncles have had this as well. Especially when you see patients who are younger, 40s, 50s, who have arthritis. So yes, it can be hereditary. We know that, patients who have arthritis in one joint are also more likely to have it in another joint. So typically patients I'm seeing for knee arthritis, I will eventually probably see for hip arthritis at some point down the road as well. So it's a good question. It's a combination of both usually.
Can you drive sooner if you have your left hip replaced versus your right hip?
So yes, I've actually had patients, and one recently that I saw, who kind of planned that based on when their husband was off work and so forth like that. So yeah, so patients who have their left side hip or knee replaced typically get back to driving quicker. In general, it's still a couple weeks, usually 2 to 3 weeks at the earliest, just because you need to be off of your any pain medicine and so forth, and just want to be able to feel comfortable getting in and out of the car. If you're doing your right side, your driving side, then in general, I'm saying at least 3 to 4 weeks, and it really depends on how quickly you can get from the gas to the brake. I just want to make sure you're able to kind of hit the brake hard if you need to stop. And that's kind of just depend on each individual person. And normally I say, go to a parking lot or a side street to kind of get going, and then see how it feels when you hit the brake. And as long as it doesn't cause pain, you can get back to driving.
Okay, next question. Who is a candidate for robotic joint replacement?
Sure. Really anybody is a candidate for robotic surgery. There's not a specific patient population for it. It's more just the surgeon preference, looking at that patient and the implant that they're using. So for me, that the robots are kind of attached to the company and the implants, and they'll kind of cross-share. So certain patients I use certain implants on because I think will work better for them. Certain patients we use the robotic implant on because we feel that will work better for them. So we try to kind of personalize that based on the patient. I would say that just to add to that, regardless of robotic or non-robotic, if you have a skilled surgeon, it doesn't make a difference either way. You'll still get a great outcome with that.
Okay, we have another hip question. If your left hip shifts up and dislocates the leg, will hip replacement help keep the hip stable?
So I'm assuming you're talking kind of like a congenital dislocation. So are there patients who have like hip dysplasia, meaning you were kind of born or kind of as you developed, your hip doesn't really sit in the socket? So yes, if that's what we're talking about, in general, a hip replacement brings that hip back into the socket and should provide stability to that. Feel free to kind of answer a follow-up question to that if I wasn't answering that exactly like you wanted. So.
Okay, next question. How do I know if I'm having hip problems versus back problems?
Very good question. So I see they're very interrelated. Okay, so patients who have low back arthritis often can have hip arthritis as well. And that's really the job of sometimes the primary care physician, more recently kind of the orthopedic surgeon, to kind of figure out the two of those. And that's figured out by both x-rays, but also really the exam and kind of the surgeon asking you questions about where your pain is located, when it hurts, and so forth. But I see that multiple times a day in the office.
Okay. Am I able to run after I have a knee replacement?
Good question. So different surgeons have different opinions on this. So my general rule of thumb is if you are a marathon runner, I don't recommend you getting back to running marathons, okay? Over time, that plastic piece only has so much wear capability, and it will wear out much sooner, okay? I have had patients who go back to doing short runs, I just say, don't train 20 miles a week. If you want to go out and run a 5K and things like that, it's okay to do once in a while, knowing that, that constant pounding activity can wear that joint out. I don't know, I can't give you a number exactly how quickly it will wear out. We just know that it will wear out sooner if you do that more on a routine basis. So I've had a couple of patients who are marathon runners. The running mentality is very much, I want to get back out there. It's just a great release and exercise and so forth. So I really kind of shift them more to say, hey, can you become like an avid biker, or do something else that really takes the pressure off the joints? Sometimes they listen well, sometimes they don't, but it's a good conversation to have. So yes, you can get back to some running, but probably not what you were used to doing if you were like a marathon runner.
Okay, there's a question that is, I missed the first portion of the webinar. Will you be emailing the recorded version? So yeah, to answer that part of the question, yes, we will be emailing out the recorded version, most likely early next week. You can watch for that to come directly to your inbox. And then contact information will also, is the second part of the question, that will also be in that email. And so I'm going to just put a last call out for questions, as that was the last, oh, actually, I spoke too soon. How long can the chiropractor keep adjusting back and hip to keep the hip in line and leg from dislocating before you have hip replacement?
So that's kind of a difficult question to answer, I would say. I would base that off of kind of an exam and an x-ray in the office. So I would say if the chiropractor is still providing relief and what they're doing is helping you, then I think it's appropriate to continue that. If you're going to a chiropractor and you've had good relief and all of a sudden it just stops working well, I think that's a time where you should kind of go kind of the next step and see a physician to kind of get a better idea of what's going on.
Great. Well, this is the last call for questions. We still have plenty of time left. So if you have any questions, feel free to type them into the Q&A. Otherwise, this is would be the final question, which is, are you accepting new patients?
Yes. Yep. Happy to see anyone. So that phone number that we kind of had back here. So the bottom there is our office number there for my office and my other partners' offices. And then once again, the premierhealth.com at the bottom right. You can go on that and search for physicians that are kind of closer to you as well. So there's plenty of options that you have, but we would love to see you.
Thank you, Dr. Davis, for your informative presentation. We appreciate your time and expertise. And I want to thank you so much for joining us this evening. I hope that you have found this information shared useful. We feel privileged to be with you tonight and hope that you consider us for any healthcare needs you may have. If you'd like to learn more about Dr. Davis or his practice, Premier Orthopedics, you can visit premierortho.com. For more information about Dr. Davis, can also be found on his bio sheet that was sent along with the information to access tonight's event. Should you have additional questions or would like to make an appointment, his office phone number is on both the practice website and on his bio.